No, welcome. I want to welcome Anne Marie McCarthy. Hold on one sec. Who is an assistant professor of epidemiology in the Division of Biostatistics, Epidemiology, and Informatics here at UPenn. And the goal of her research is to reduce the burden of cancer through improved prevention and screening strategies, particularly for racial, ethnic, and other type ethnic minorities. Her work seeks to integrate genomics into clinical care and to develop tailored prevention strategies based on individual patient risk and to implement precision medicine approaches to breast cancer prevention and early detection. And we were really pleased to award one of the Global Genomics and Health Equity pilot grants to Anne Marie and her colleagues, and we look forward to hearing more about your project.
Wonderful. Thanks so much, Sarah, for the invitation to speak here today and for the generous support of the GGHG. That's really helped us expand and drive this line of research forward. So I really appreciate it. So let me share my screen. Gotta share first, I think, and then here we go. Okay, can everyone see this?
Yes. Yep.
Wonderful. So as Sarah mentioned, I'm a cancer epidemiologist, and so today I'm going to talk about my pilot-funded work identifying SNPs associated with volumetric breast density among Black women. We've made great progress, and we have some results of a very preliminary smallish GWAS of breast density, which I'll talk about at the end. But really the first half of the talk, I'll be giving you the background on breast cancer disparities in the US, talking about what is precision screening and racial disparities and how precision screening and racial disparities might interact. And then I'll focus a lot of time talking about breast density, its relationship to breast cancer risk, and how it might be useful for precision screening. And then finally, I'll talk a little bit about our GWAS results, and I'd love to hear your thoughts on directions to go in that regard. I'll give the caveat that while I'm interested in integrating genetics into breast cancer prevention, I'm not a genetic epidemiologist. I'm not a statistical geneticist. So happy to hear your thoughts on how we might make this work more rigorous. So first, I'll start with kind of a background on breast cancer disparities here in the United States. Black women in the US have 40% higher breast cancer mortality than white women. And that's despite the fact that Black women are actually less likely to get breast cancer than white women. So this figure here shows breast cancer mortality rates over time from the mid-70s till early or right before 2020. And the light pink here represents the mortality rates for non-Hispanic Black women over time, and the darker pink is non-Hispanic white women over time. And as you can see, in the early days, prior to kind of early to mid 80s, there really wasn't a disparity, but we did see, we see these mortality curves diverging around the early 1980s. And what happened during that time was we implemented better treatments for breast cancer. So that's the advent of tamoxifen and other aromatase inhibitors into breast cancer treatment. And we also started mammography screening on a large scale. And so when these two interventions became available, unfortunately, they were implemented in an inequitable way that led to this large disparity in mortality between Black and white women. And what you see here is though mortality rates are declining for pretty much all populations over time, which is fantastic. Unfortunately, this disparity is quite stubborn and hasn't narrowed over time. And this is in contrast to what we see in other cancers, even other cancers in women like cervical cancer. In some of these other cancers, we're seeing the racial disparity narrow over time as we're getting better at screening equity and treatment equity. Breast cancer, it's been really consistent and has not really narrowed. And so this kind of demonstrates the need for novel approaches to breast cancer prevention and screening. And this was another graph that I saw that I felt was really striking and really brought home the severity and the impact of these disparities. So this map shows the number of additional deaths among Black women when you compare 100 Black breast cancer patients to 100 white breast cancer patients. And on average in the US, per 100 breast cancer patients, there's 9 more deaths among Black women than among white women. And this is really emblematic of the large impact that systemic racism has had and continues to have in our country. It shows that there's differences across different geographic regions in the United States, and just, really, to me, motivates the work that we're doing to try to figure out a better way forward so that we can start to ameliorate this large and unacceptable disparity. This graph shows the stage of diagnosis for breast cancer. For Black women, it's this brownish yellow bar, and for white women, it's the blue bar. And what we can see is among women diagnosed with breast cancer, a higher proportion of Black women are diagnosed at a regional or distant stage. And at these stages, breast cancer treatment is much less effective. And so this really nails home the point that while we definitely need to work on improved treatments and improved therapies and better access to those treatments and therapies, we also need to continue to work on prevention and doing a better job at detecting breast cancers in Black women at an earlier, most treatable phase. And so in breast cancer, we have a very effective screening tool. Mammography screening has been shown in randomized controlled trials to reduce breast cancer mortality 15 to 20%. However, like all screening tests, mammography is not perfect. There is a significant false positive rate. So many women need additional imaging or biopsies to rule out cancer, which increases burden on patients and as well as costs. In addition to false positives, there's a substantial false negative rate for mammography screening as well. Mammography screening has about 85% sensitivity for detecting breast cancers, and about 15% of breast cancers are missed on a mammogram or are diagnosed within the screening interval. So the absolute risk of having a false negative is about 0.8 per 1,000 women screened. And so in 2016, which is a long time ago now, but the USPSTF changed its breast cancer screening guidelines. It changed from every year starting at age 40 to every other year starting at age 50. And they mentioned that for women in their 40s, whether to screen or not for breast cancer should be a personal decision based on risk factors and personal preferences. Other screening organizations have different recommendations, but really what we're telling women is in their 40s, do what you want. And I think that we really need to do better than that. And we have a large evidence base to be able to give women better recommendations than just talk to your doctor and figure it out without telling women what factors to think about when they should figure it out. This also is particularly concerning for Black women who tend to be diagnosed at a younger age than white women on average, and who tend to be diagnosed at a higher rate with triple negative breast cancer, which is more aggressive, grows faster, and is actually harder to detect on a mammogram. So many scientists and advocates have raised concerns about this USPSTF guideline recommendation for Black women, saying that it might lead to even larger disparities and lead to later diagnosis among Black women. We've been doing kind of the same thing for a long time in terms of breast cancer prevention, and I think it's really time to think about innovation. And one innovative intervention that is emerging is breast MRI screening. And so breast MRI screening's more sensitive than mammography. It detects cancers that just are not visible on mammograms. And it's currently used primarily for women with a greater than 20% lifetime risk, which tends to be women with BRCA mutations or other high penetrance mutations, or women with a very strong family history. So this is the use of MRI is increasing. However, its costs are higher. There's limited access. Women need to get an IV to get the MRI, to get the contrast agent, and it has a significant false positive rate that leads to biopsy. However, here at Penn, we're developing new MRI procedures that called the abbreviated MRI, which takes a 30-minute exam time down to 10 minutes. So a large focus of my research is figuring out which women might benefit from MRI screening and how we might implement it to improve outcomes. And so this idea of moving from a one-size-fits-all strategy for mammography screening to a more precision screening approach, it has gotten a lot of traction, although we haven't really done a good job of implementing it yet. And so the questions we might ask for precision screening are, when should I start screening? Should I start screening at 40 or 50? Or if I have a family history, should I start before 40? How often should I be screened? Should I be getting screening every year or every other year? And then what type of screening should I use? So should I just be getting mammograms, or should I also be getting supplemental screening with breast ultrasound or MRI? And so one main question we have is, how do we assess risk? And one of the factors that I'm going to talk about today that is a very strong risk factor for breast cancer is breast density. So breast density is the relative amount of the fibroglandular tissue relative to the fat tissue in the breast. And so here we have 4 mammogram images of 4 women with different levels of breast density from lowest to highest. And so on a mammogram, the fibroglandular tissue, so the ductal and lobular tissue, shows up as white, whereas the fat tissue is black and is not visible on the X-ray. And so here, for a woman, this category is called almost entirely fatty. This woman does not have a lot of fibroglandular tissue, which makes it really easy to see a tumor if it arises. And so I'm not a radiologist, but I can see that this looks like a tumor, and I can see that this looks like a tumor. When you go to higher levels of density, it can be more difficult for the mammogram or the radiologist to see a tumor on a mammogram, and you can see marked here, there's tumors here where these little dots are, but even the radiologists have a hard time seeing this. And so as breast density level increases, the risk of developing cancer increases. So such that women in the highest category of breast density have a 4-fold increased risk of developing breast cancer compared to women in the lowest level of density.
Anne Marie, I have a question about that.
Yes.
I mean, is that just because of the detection as opposed to some kind of like a biological reason?
Thanks for clarifying. So this estimate is based on the future risk of breast cancer. So taking out the women who, lagging risk for breast cancer. And so, the lobular and ductal tissue, that's the tissue that gives rise to ductal and lobular carcinomas. So we think, as my colleague Emily Conant likes to say, dense tissue is kind of the garden where breast cancers can grow. So there's definitely an increased risk due to the higher amount of dense tissue. However, you're right that there's kind of this 2-level increased risk for breast density, and the other level of risk is related to detection. So women with higher density, the performance of mammography is decreased. So for women in the lowest density category, mammography sensitivity is about 88%, and in the extremely dense, it's only about 63%. So again, this dense tissue is making it harder to detect cancers, and therefore they often aren't detected until they're at a later stage, which is harder to treat. So breast density really increases risk in 2 ways, which is why it's such an important breast cancer risk factor to think about. It's also, the highest level of density, it's about 7% of women in the US have extremely dense breasts. When we look at these top 2 categories, it's more like 30 to 50%. And I'll show you some more data from Penn on the prevalence of breast density. This is just a clinical case of a 42-year-old woman who had a negative mammogram, a DBT mammogram, the 3D mammogram. So this is a 2D and a 3D image of the breast. The radiologist did not see a tumor here. The woman came back 3 months later and had a 2-centimeter breast cancer, which is not considered small. And it was visible both on ultrasound and on MRI. It was a triple negative breast cancer. So this just is, a real case example of what can happen when women have extremely dense breasts and are not undergoing supplemental screening. So in 2019, a large randomized controlled trial was reported of supplemental breast screening with MRI, focused on the women in the highest extremely dense breast category. And this trial was performed in the Netherlands. And so what they found is the interval cancer rate, so the rate of getting a cancer detected after a negative mammogram before your next scheduled mammogram, was 5 per 1,000 screens in the women who only got mammography, or in the mammography only group. That was intention to treat analysis here. And it was only 2.5 per 1,000 in the group that got invited to get MRIs. And so this represents a 50% reduction in the interval cancer rate among women with extremely dense breasts. And of note, the cancers that were detected by MRI, over 80% were invasive and less than 20% were DCIS. So one concern with MRI screening was we're just going to detect a lot of DCIS that's not going to be as clinically significant, and it'll lead to overdiagnosis. But that really wasn't seen in this trial. It's mostly invasive cancers. And really, it seems like it's detecting cancers that just aren't visible on mammography. And so based on this and the greater understanding of the importance of breast density, there's been a big push for legislation to both inform women about their breast density level and enable insurance coverage for supplemental screening. And so this was really legislation that was driven by advocacy groups primarily, so women who have experienced a breast cancer after having dense breasts. And so this is a recent map of the US, and the pink states are states that have dense breast density notification laws in place. And then just a month or two ago, the FDA mandated notification at the federal level. So now all states need to notify women if they have dense breasts. And then some states, a subset of states, have additionally expanded insurance coverage. And as you can see, Pennsylvania has expanded insurance coverage for breast imaging. And so this law passed in the Pennsylvania Congress, the Pennsylvania legislator. I think it passed in 2020 and went into effect in 2021. And this requires insurers to cover supplemental screening for patients with extremely dense breasts and some other risk factors. While coverage is mandated, co-pays are not mandated, and they're allowable. So while insurers need to cover it, there's no prohibition for co-pays and co-insurance and deductibles. So patients may still have out-of-pocket costs that put this out of reach.
And Anne Marie, it was, can you go back one?
Yep.
So I was surprised by this distribution of who covers with insurance, because I thought maybe I'd see a blue state, red state kind of thing, but it's like East Coast, or sort of take the middle of the country and just enrich for people on the right side.
There are differences in terms of what that insurance coverage means. So some states might be more proscriptive, whereas others might be less prescriptive. But I think it's a good point that it doesn't necessarily follow where you might expect this legislation to pass. And I think there's a lot of reasons, everything from advocacy groups to whether, I know our cancer center was a strong advocate of this. So I don't know if MD Anderson in Texas got involved and was lobbying for this. And, I do think that's interesting, and it'll be interesting to see how things develop over time. As many of these laws passed even before the trial results came out based on advocacy work. But now that we're seeing actual evidence accumulate, I think that we might see an expansion here.
Right.
And then just another interesting thing to note is that in March, the Pennsylvania Senate passed unanimously a new law that would both require insurance coverage and prohibit out-of-pocket costs, both for BRCA testing and for breast cancer screening and supplemental screening. So this bill is moving on to the House of Representatives, and I expect if it passed so easily in the Senate, it would pass in the House as well. So stay tuned, because I think this is a really great, this would be a really great law for expanding accessibility of these screening and testing for women in Pennsylvania. Okay, so this is looking at Penn data. This is women who got mammograms at Penn in a 2-year period, and this is showing the distribution of breast density by race. So this is for white women, this is for Black women. And so as you can see, we've got a higher proportion of white women in the 2 highest categories of density than we have Black women. Black women tend to have lower breast density. So these columns are looking at the true positives. So these are breast cancers that were diagnosed in the mammogram, and the cancer detection rate per 1,000. And then these are the false negatives. So these are the cancers that were diagnosed within a year of a negative mammogram. And then this is the rate of these false negatives per 1,000 screens. And so if we look at the extremely dense group, for both Black and white women, women with extremely dense breasts have the highest rate of false negatives. So you see that the interval cancer rate is 1.5, 1.3 per 1,000 women. But interestingly, when we look at the absolute number of false negatives, for white women, most of the false negatives occur among women with dense breasts. But when we look at the absolute numbers of Black women, most of the false negatives do not occur in women with the highest 2 levels of dense breasts. So what's going on here? So when I showed you the 4 levels of breast density, those 4 levels are coded visually and subjectively by the radiologist. So the radiologist looks at the mammogram and just decides this is a category 1, 2, 3, or 4 density. And we've seen that women who have higher BMI tend to have lower breast density. And I think what's happening there is that you've got more fat tissue in the breast, so it makes your level of breast density look less on a relative basis. And so the question we had was whether this difference in breast density that you see between Black and white women, is this just because of BMI? And if we account for BMI, do we see similar levels of density, or is it due to other risk factors? And so back in 2016, we did a study among women screened at Penn. We had about 4,000 white women, 5,000 Black women, looked at breast density levels. And so again, we saw differences by race, and we were wondering if these were explained by factors that we could measure. And then we were also wondering whether a quantitative measure of density would be better at assessing breast density, particularly for Black women. And for this work, I collaborate very closely with Despina Cantos, who's a computer scientist in the radiology department who's developing novel breast imaging measures. And so she developed an automated algorithm to quantify breast density. It's called Libra, and it's a free shareware software program that runs on mammogram images. So it's able to segment the breast area and segment the dense versus non-dense tissue and come up with quantitative measurements of the breast density level. And so we used these measures, and then we adjusted for factors such as age, BMI, other risk factors. And here we're looking at BI-RADS density. And so when we looked at the BI-RADS density, so that's the radiologist measurement, when we took into account age and BMI and other risk factors, we didn't see a difference in BI-RADS density between Black and white women. But interestingly, when we looked at our quantitative measures, such as percent density, the area percent density or volume percent density, we saw Black women actually had higher levels of breast density than white women, and that was even after adjusting for BMI and also stratifying for BMI. So this is interesting and really gets to the point of whether it's the percent of dense tissue or the amount of dense tissue that's important for risk. And so you can just see here kind of what we're talking about here. So these are 4 different breast images. These are on the same scale, it's just different breast sizes. And so all of these women have the same percent breast density. So they all have 25% breast density, but you can see the absolute amount of dense tissue varies quite a bit. So I think this is particularly important for Black women because Black women tend to have larger breast size, more fat tissue in the breast. And so perhaps we're not measuring breast density well in Black women. And maybe absolute volume is a better predictor. And so the other thing I want to call your attention to, I'm just going to flip back a few slides. I forgot to mention this, but if we're talking about directing supplemental screening based on breast density, Black women are going to be less likely to qualify for breast MRI, despite the fact that they have higher risk of dying of breast cancer, and despite the fact that we're seeing false negatives among patients without dense breasts for Black women. So if we're using density alone and this BI-RADS measure of breast density, we might actually exacerbate or open up additional disparities in outcomes. Okay, sorry, just flip through. So we're moving now. So the data that I showed you was based on 2-dimensional images, but in the past 10 years or so, digital breast tomosynthesis has really taken over the mammography landscape. And that is a method of breast imaging that uses multiple views across by basically moving the X-ray and taking multiple X-rays, and then those multiple X-rays can be put together to make a quasi 3D image of the breast. And so this is important because it gives better visualization of breast tissue, allows you to kind of flip through the stack of images. So if there's some dense tissue that's blocking one area of the breast, perhaps if you do an image at a different angle, you might be able to get better visualization. And it also allows more 3D quantification of breast density. So Dr. Cantos has additionally developed a 3D algorithm for quantifying the actual volume of dense tissue and non-dense tissue in the breast. And we think that this will be even more accurate at both quantifying dense breast tissue and also predicting risk. And so this is just a very preliminary study. It's 62 cases in Black and white women. And this is the 2D breast density, and this is the 3D breast density. And you see for both Black and white women, the 3D measure of breast density was more strongly associated with breast cancer risk. And if we look at the predictive value, though this is not statistically significant, it's close to statistically significant for Black women and suggests that the 3D measurement of breast density might do a better job of assessing risk. And so just kind of reiterating and summarizing all of the many things I told you, there's large persistent racial disparities in breast cancer mortality and stage of diagnosis. Breast density is a very strong risk factor for breast cancer, but Black women are categorized as having lower breast density than white women using subjective BI-RADS breast density. What we've seen from our quantitative studies is that Black women actually have a greater amount of dense breast tissue, and that current methods might result in racial disparities in use of supplemental screening. We now have the ability to measure volumetric breast density, and that might be a better risk marker among Black women. And I'm not going to go into great detail, but we actually don't know very much about the biological underpinnings of breast density and risk, why we see differences between people in terms of breast cancer risk, or in terms of breast density. So there have been some studies of the genetics of breast density, and it's been shown that breast density is highly heritable. So 50 to 70% of the variance in breast density can be explained by genetics. And there's about 50 genetic loci that have been previously identified in GWAS studies as associated with breast density levels. However, there's been 0 studies of breast density and genetics among African ancestry populations. And another thing to note is that the prior studies really focused on the 2D measurements of breast density. And so what we've proposed to do in our pilot grant with my co-investigators, Shefali Setyavarma and Despina Cantos, is to perform the first GWAS of volumetric breast density among Black women. And then once we perform that GWAS, second aim is to develop a polygenic risk score for volumetric breast density, and then look at whether that polygenic risk score for density is associated with breast cancer risk. And so why would we need a polygenic risk score for volumetric density? Well, Unfortunately, we don't know what your breast density is until you get a mammogram. So until we get a mammogram, we don't know density right now. So if we did have a way of looking at your genetic propensity to having dense breasts, then we might be able to factor that in our precision screening recommendations. So you might choose to screen earlier if you have a propensity to dense breasts, and you might choose to think about supplemental screening with MRI in addition to mammography. It also might, this GWAS might give us some clues as to the biological associations and what factors are really driving both breast density levels and also racial differences in breast density levels. And so we've done a preliminary study. This is in women with self-reported Black or African American race. Women in their 40s to 80s who underwent mammography in 2010 to 2014. Now, I'll just make the point that this first result I'm going to show you is digital mammography, and we're using our pilot funds to expand this to look at volumetric breast density. And so this includes women who consented and had genotype available from the PMBB. So we're really excited and doing a lot of work trying to combine our mammography screening cohorts with PMBB. And for this analysis, we excluded BRCA mutation carriers, patients who already had breast cancer prior to the mammogram, patients with breast implants who didn't have images available or for whom the algorithm failed, which was a small proportion of patients. And so for this initial study, we had about 1,300 women who had both genotype information and mammogram images. You can see the quantitative breast density measurements that we derived from those images. The average age was about 56. Of note, the average body mass index was quite high, 33, which is in the obese range. And then we can see in this particular set of women, breast density was actually, there were very few women who were coded as having extremely dense breasts, probably partly because of the high BMI. And about 12% of women reported a family history of breast cancer. And so we did a preliminary GWAS in this group of 1,300 women on the amount of breast area. So that's basically breast size. The green is percent density. So that's the amount of dense tissue divided by the breast area. And then on the amount of dense area, which is in the dark region. And we actually, despite the relatively small sample size, those are all continuous variables. So we had a little bit of statistical power, and we're able to identify 65 significant SNPs at genome-wide significance. And that represented 29 independent loci for dense area. And then we also identified 9 SNPs associated with percent density, of which there were 5 independent loci. And so this is the Manhattan plot. And the pink are the gene regions where these SNPs located to, and then the yellow are genes that have been previously implicated in this case in breast cancer studies. We actually didn't get any hits at genome-wide significance of the SNPs that were previously associated with density among white women, or I'm sorry, among European ancestry women. And so we just looked using a less stringent threshold, using a threshold of 10 to the -5th. We looked at whether we were seeing any overlap in terms of the loci that we were identifying versus loci that have been previously identified as associated with either breast density or breast cancer. And so as you can see here, we've got these are our loci that we identified in this study, 625 at this p-value threshold. And then of those, about 57 loci had been previously identified as associated with breast cancer among European ancestry populations. And then 6 loci that we identified as associated with density have been identified previously as associated with breast cancer among African ancestry populations. And then when we use this this less stringent p-value, we actually got 13 loci that overlapped between our study and the European ancestry breast density GWAS. And so this is, we recognize that this is a small study. We need to follow this up in much larger populations, but at least gives us some proof of concept that there is potentially value to assessing breast density SNPs among African ancestry populations. We did some fine mapping and again found several genes that through fine mapping, and some of these had previous associations that made sense or seemed like reasonable targets to further pursue. So this is phosphodiesterase 10A, which has been shown to have an oncogenic effect in ovarian cancer. And there is SH3GL3, a non-coding RNA that's been shown to be a tumor suppressor in glioblastoma and lung cancer, and also is involved in cell migration and invasion, and was also identified in a colorectal cancer GWAS. And then we also identified KIFC3, which has been shown to be associated with resistance to docetaxel and breast cancer. And so we think some of the GWAS results we get might give us clues to what the underlying biology is that's driving breast cancer or breast density levels, and might be hypothesis generating for future research.
Anne Marie, can I? Yeah, I have a question about that. So I noticed, relatively large numbers say annotation is heterochromatin. Can you tell me more about that?
Yeah, I think that's on the limit of my knowledge of the impact of that. These were again what came out of fine mapping. Unfortunately, Shefali was not able to join.
Sorry,
I'm
not here. Sorry, I just
hi, Shefali. Do you have any thoughts on the heterochromatin result?
Yeah, so yeah, that's a great question, Sarah. These are the annotations that we get from the epi map. So it is where the SNP maps in the regulatory region is why the heterochromatin annotation is. They're just mapping to the chromatin states using the ChroMHMM models. So we're just using exactly that annotation here.
Oh, okay. So this is like you said, it's based on epigenetic annotations.
Yes.
Okay. I'd be curious, non-epigenetic, what else it's doing. But I guess on the right we can see the ones that are relevant to cancer. I mean, really interesting. Okay, thank you.
Yeah, we also did some PFAS, and so this figure shows traits that were associated with 2 of the genes that we identified, at least 2. And so we see some interesting potential phenotypes that are popping up, such as body measurements. So thinking about breast density and BMI, cancer, cardiovascular disease, immune. And so cardiovascular diseases, lipid measurements, immune system diseases, and body mass index all had at least 3 hits in our PFAS. So again, this is also very interesting. There's been some studies showing impact of the insulin pathway on breast density. So that's, I think, an interesting area that we could further follow up on. And then just in terms of the GWAS catalog lookup, some suggestive SNPs here. And again, some of these SNPs, I think interesting breast size came out, and then 2 bone density measures, which I think might be, we do see actual associations between bone mineral density and estrogen levels and breast cancer risk. So I think that's an interesting hypothesis generation that we might want to look at that. And also sex hormone binding globulin. So we're seeing some things that would suggest that there might be some actual value of these findings for future hypothesis generation and future evaluative studies. And so our next steps, we're going to repeat our GWAS in a larger sample using 3D volumetric breast density from DBT images. And so this shows where we're at right now in terms of, this is patients, and then these are breast images among these patients. So in total, we've got 6,500 patients or women who had a mammogram and are in PMVB. And of those, we have DNA on about 5,600. And so right now we've got about 2,700 Black women who will be included in our larger GWAS. And this number is increasing very quickly. And we expect to get more data back from Regeneron that might allow us to do an even larger GWAS coming up soon. And so we've already pulled all of these images, and we're currently in the process of the volumetric breast density quantification. And then once we get that, we'll be able to generate and test our breast density PRS. And then just some extensions, directions we'd like to go. So we really want to think more about both the genetic and the environmental behavioral factors that explain racial differences in breast density. And we were recently funded by the American Cancer Society with a research scholar grant that actually looks at what factors might be driving racial differences beyond BMI alone. And then our second aim, I'm doing a pilot study with the Implementation Science Center for Cancer Control here at Penn. It's headed by Ravi Chanel and Nat Baidas and Justin Beckelman. And so we have a study where we're testing breast density notification to patients and providers to see if this increases utilization of supplemental breast screening. And then based on our results down the road, we might be able to expand this to use some of our quantitative measures of breast density or even our breast density PRS when we're notifying women of their risk. And finally, we have working with Dr. Kantos, she's developed even more novel metrics beyond just breast density. So she's extracted radiomic features that are really getting at the breast parenchymal complexity. And so this is a heat map actually of the radiomic features that her lab is able to extract and some clustering of those features. And so this is kind of the next step beyond just looking at breast density, looking at whether some of these patterns of what we see in the breast image correlate with genetic factors. And so Shefali and I had a pilot grant from ITMAT to do this, and we're really excited about expanding on this area as well. And so these are our collaborators on this project. We'd like to particularly thank the Penn Center for Global Genomics and Health Equity for funding this work. And so happy to take any questions you might have.
Yes, awesome. Thanks so much. That is really, really interesting. I guess I'm surprised how strong that you saw so many associations with such a small sample size. So I take it that these are a pretty large effect then. Is that correct? Like the associations you see? Yeah.
Some of these are pretty large effects, but we also have a lot, because of the small sample size, we have larger standard errors on these as well. So that's why, a lot of them do not replicate, and adding more sample size and replication would really help here.
Yeah, although the fact that they overlap as much as they do with the phenotypes that you'd expect and with the other studies is like super interesting.
Yeah, I think part of it too is it's because it is a quantitative trait, and we're getting so good at measuring it that, we do have, even though it's not a large sample, there is a pretty decent distribution of breast density across that sample, which might be giving us some power there. And it is a highly heritable trait as well, which we already know. So, I was pleasantly surprised. I was honestly pleasantly surprised that anything came out as
no, but I'm actually wondering if that is it actually. I mean, both the fact that it's highly heritable, but the phenotype that you're able to it's so much more specific than when we study diabetes or we study, things that could have so many different underlying factors, and the phenotype is kind of broad and things like that. It's really remarkable.
Yeah, thank you. Yeah, I agree. It's, because we're also measuring this on everyone. And when you're thinking about a trait like diabetes, you're also, you're not necessarily detecting everybody who's got diabetes. There's some people who have undiagnosed diabetes that are, probably attenuating your association you're seeing. Whereas here we're directly measuring it on everybody who's coming in. So, so I think that there's something there, and I'm really excited to see our larger sample, whether we're replicating. And perhaps with this, again, this was with a 2D measurement. Now that we're getting the 3D quantification, will we have even more power since we're getting even more potential accuracy in the quantitation? I think that could be really interesting to see.
And then if you were able to come up with a polygenic risk score that is fairly predictive in this population, then is the plan to think about ways to implement that, or are people at the biobank like thinking about, like, I mean, I know there's lots of controversy about polygenic risk scores generally, and most of them don't replicate across people of diverse ancestries, but here you're actually looking in this population.
Yeah, it's a great question. I mean, I think we would have several steps before this could get clinically implemented, but I think with the biobank, it gives us the opportunity to do this. And these patients are coming in for mammograms often, so it's not like we're never going to see them again, and there's not actionable things that they could do. So, I think there are a lot of really exciting opportunities, particularly with this insurance coverage law coming out. We could actually identify patients who have never gotten a mammogram in their 40s and reach out to them and say, I think this, we're trying to figure out, how do we use the EHR and how do we automate things to improve outcomes, and how do we do this precision screening? And I think there's the opportunity here to, we really can't do high touch for everyone because it's difficult. But, if we think about who are we really most worried about not getting screening, it would be patients with a family history, probably be patients with dense breasts. And if we can identify those patients, from the biobank ahead of time, we might be able to, or with, a polygenic risk score ahead of time, then we might really be able to target those patients and say, look, your risk is particularly high. You should get in and get a mammogram now. And I took this slide out, but there was a really interesting study in federally qualified health centers where they did risk assessment in the federally qualified health systems and gave women information about how their breast cancer risk compared to other women of their same age. And it actually found that women with higher risk who got the risk assessment and their risk was higher, they were more likely to go and get a mammogram than patients whose risks were lower and who did not have their risk assessed. So, I mean, I think that there could be some potential to kind of bring this to women's attention and make it important, and also continuing to screen. So some patients might get their first mammogram and then they get busy, they don't come back next year, they don't come back in 2 years, they kind of lose track. And so this might be another way to kind of give women information that would allow them to understand the importance of coming back frequently.
And can you just, well, first of all, if there's anybody else with questions, please feel free, jump in or raise your hand and I can identify you. Remind me again the differences between people of European ancestry and African ancestry. Just if I recall, you said there were fewer, right? Of relatively fewer, well, what's the word? In people of African ancestry, not as large a percentage had very dense breasts. Is that correct? I just want to make sure.
Let me find you that slide. Yes. So Black women had lower breast density when we do our when we use the typical. So
the typical, right?
Yeah, the visual.
And when you had the other.
So when we have the other, I don't have the data on here, but basically when we use the percentage, Black women have a lower percentage of density. But when we use the absolute amount of dense area, they have higher amounts. So that's getting kind of to this point. So again, like in white women or in European ancestry populations, the percent density has been the more used metric. Whereas it seems like perhaps in women of African ancestry, maybe the absolute dense area is going to be the better measure. And that's kind of what we're seeing. Where is it? Where did I get the, so that's where, sorry. That's that very preliminary study. Yeah, this one. I mean, this is all percent, but so that's another thing that we're very interested in evaluating, and the grant that recently got funded from ACS is going to look at that as well.
Great. Alex Platt, I see you have a question.
Yeah, so that was very interesting. Thank you. One thing that I'm finding myself thinking and wishing I could see the results of are a GWAS that used multiple of these measures at the same time. So not separate GWAS where we have to then compare, does this replicate, does it not replicate, what's the p-value of this SNP, but a combined analysis that could tell me this SNP is having this joint impact on these different related measurements. And some way to see in what sense are these SNPs working together as a common underlying factor that we're seeing reflected in all of these measurements, and to what extent are we finding SNPs that are actually affecting the risk in different ways that are being picked up differently across these different risk factors. So I'm just throwing that out as something I would love to see myself, and you may or may not be interested in doing.
No, I thanks for that comment. I think that would be really interesting, particularly if we're thinking about like, why is the SNP associated with breast density? And it could be associated because it increases the amount of dense tissue, or it could be associated because it reduces the amount of fat tissue. And so I think that's what you're getting at, right? Like trying to put these three measures together in some way.
Right, and if you can combine that additionally with actual breast cancer risks, and to try to figure out sort of what's going through these pathways, what's going around them, and how are these measurements actually indicative of how the genetics is, or the genetics plus those other cofactors leading into breast cancer risks and breast cancer outcomes. Fascinating.
Yeah, that's a really good point. And I have another pilot study that's trying to get at the effect of obesity on density and using Mendelian randomization. So like using the obesity SNPs and seeing how that's associated with density, and is it different aspects of obesity? So is it insulin pathway, or is it inflammation pathway with obesity? So I think that there's a lot of opportunity here to use genetics to do stuff that we just can't do in epidemiologic studies because it's so confounded by every other thing. So I just really excited by the biobank getting bigger and bigger. We have to wait a little bit longer before it gets, I think, big enough that we can really start teasing apart like subsets of SNPs that are associated with different parts of density and which of those are more associated with breast cancer risk. But I think it's a fascinating area. I also think like perhaps the interaction of, something I've been thinking about is is there some interaction between the fat tissue and the dense tissue, and how does that relate to breast cancer risk? And then kind of the other thing we didn't talk about at all, because again, we need more power, but thinking about different types of breast cancer. So like triple negative breast cancer versus ER positive. And so the studies that we've seen so far, it looks like breast density is associated with a higher risk of all forms of breast cancer. But maybe we could tease apart, how density or specific types of density or pathways of density are associated with like triple negative breast cancer, which affects Black women at a higher rate. And that could be super interesting as well.
Great. And Matt, you had a question?
Yeah, hi. Can you?
They're in the same room, so
Okay,
they probably have to
sorry.
have one person shut up.
Doing,
Yeah.
volume controls. So yeah, great talk and very interesting. I was wondering when looking at the Venn diagram overlaps, and maybe I just missed this. Were those like for the exact same variants, or are those like, I'm wondering about like different ancestries? These are not causal variants, so they might be tagging. You might see things that don't look like they overlap, when in fact they're tagging. There might be a tagging issue. Yeah.
Yeah. So Shefali, this is loci we're looking at, right?
Yeah, my recollection is also that we're looking at 250 kb upstream and downstream of each of the loci that were previously identified and see if they are in our 625 list. So like, the 6 breast cancer loci that are in the African ancestry, we're looking 250 kb upstream and downstream to see if any of the variants in that range are in 625 list. But I can double check on that, what that range was. Is it 250 or 500? And the 500 kb, I don't remember it exactly.
I see. No, it's interesting, right? So you
Yeah,
have,
but I think your point, I think this is kind of the point you're making, right? Like, we only saw 13 overlap between the European ancestry loci and our list of loci. So I think that definitely could be, the point could be the tagging SNP and the genetic architecture being different.
yeah, right. I mean, this could be obviously super useful for fine mapping and actual common causal variant.
So we are actually about out of time. So thank you so much, Anne Marie and Shefali. It's a really exciting study, and we're really happy to help fund it and to see how much success you're having. So again, everybody, thanks for coming, and we'll see you at the next talk.
Great, thank you so much.
All right, bye-bye.
Okay.